carcinoid tumor. Pulmonary carcinoid tumor and other primary lung tumors. Primary pulmonary carcinoid tumor comprise من 4 ل 3% of lung cancer, and lungs are the second most common site for carcinoid tumor. Lung is the second most common site for pulmonary carcinoid tumor. WHO classifies carcinoid tumor into typical يعني أقل من 2 mitotic figures per 10 high power field with no necrosis, or atypical من 2 ل 10 mitotic figures with tissue necrosis and architectural disruption. Typical and atypical tumors have the ability to metastasize and invade local structures, and therefore both are considered malignant lesions. In most series of resected tumors, من 15 ل 20% are atypical carcinoid tumors, with the remainder being typical carcinoids. According to the WHO, carcinoid tumors are considered part of neuroendocrine tumors. Typical carcinoid tumors low grade, with atypical carcinoid tumors intermediate grade, and the large cell neuroendocrine tumors and small cell lung cancer high grade. Clinical presentation. The median age at presentation is 48 years, with bimodal age من 35 ل 55. Patients older than 50 years have higher incidence of atypical lesions than those younger than 13 years. Gender distribution is approximately even. 1/3 of patients are asymptomatic. Among those with symptoms, recurrent pneumonia, cough, and hemoptysis are the most common presenting symptoms. Carcinoid tumors may release ectopic hormones such as ACTH, vasopressin, insulin, and 5-hydroxytryptophan. Carcinoid syndrome is uncommon in localized disease. However, approximately 5% of patients will develop Cushing's syndrome with localized disease. Diagnosis of carcinoid tumor اللي هي malignant. Chest X-ray findings are non-specific and related to the location of the tumor. 50% of atypical and 70% of typical carcinoid are centrally located. 75% of these being found in the lobar or subsegmental bronchus. CT finding of carcinoid tumor are characteristic, with peripheral carcinoids have smooth rounded homogeneous appearance, and central lesions have obvious airway component and post-obstructive atelectasis or pneumonitis. Positron emission tomography and octeroid scan are often obtained. However, data are conflicting and neither can be recommended as routine studies in diagnosis or staging of carcinoid. Bronchoscopy and biopsy for tissue diagnosis is important for patients with central necrosis of central lesions. Needle-guided biopsy should be used for peripheral lesions. It is well established that these lesions can be biopsied safely. Despite adequate tissue, diagnosis of carcinoid is only made in 70% to 80% of the time preoperatively. Distinction between typical and atypical carcinoid is even less accurate. Clinical factors such as patient age, tumor location, and radiographic findings, including nodal status, often support the clinical diagnosis and histological type of carcinoid, even in absence of tissue diagnosis. Most peripheral and central carcinoid tumors without evidence of nodal disease will be typical and require no further evaluation prior resection. In contrast, 50% of central carcinoids و 50 ل 70% of peripheral carcinoid tumors with N1 or N2 disease will be atypical carcinoid, and these patients should have thorough staging workup for metastatic disease, including mediastinoscopy prior to resection. treatment of carcinoid lung disease أو carcinoid lung tumor. Surgical resection is the main treatment for carcinoid tumor. A limited resection is acceptable for typical carcinoid as long as R0 status يعني no residual tumor is achieved. Mediastinal lymph node dissection should be performed for any clinical nodal disease and atypical lesions. Even those with N2 disease have good survival with complete resection. Adjuvant chemotherapy either preoperatively if N2 disease is detected during staging or postoperatively for pathological N2 disease is given in some centers with response rates similar to that seen with non-small cell lung cancer. The data supporting this approach is limited. Endobronchial resection of carcinoid tumor has been attempted for patients who are unable to tolerate parenchymal resection. However, every effort should be made to attain negative margin as these patients will recur locally. Tumorlets والtypical carcinoid tumor أقل من 5 سنتيمتر can be seen in 10% of patients with primary carcinoid or other types of non-small cell lung cancer. They are more common in women and older patients. It is unclear, however, these patients have worse survival, but tumorlets should be staged as metastatic disease, and the treatment should be based on the primary lesion. Metastatic and unresectable carcinoid often treated with chemotherapy, while the value of radiotherapy is less clear and not often reported. Chemotherapy response rates vary from 20 إلى 38%, while as many as 30% will progress on therapy. Small cell regimen seem to provide most of response. It is recommended that carcinoid patients be followed for 20 years because of the indolent nature of the disease. ماشي. Other primary malignant tumors include adenoid cystic carcinoma, which is a tumor of the trachea and the main stem bronchi that is usually detected only with onset of symptoms, often with significant obstructive component. Submucosal extension beyond gross intraluminal tumor is the rule with these lesions, and the intraoperative frozen section of the bronchial margin to ensure complete resection is essential when resecting adenoid cystic carcinoma. Other salivary gland type tumors include mucoepidermoid and acinic cell carcinoma. These are all malignant lesions with a usually indolent course. However, local invasion and nodal metastasis are possible. These lesions account for 1% of all primary lung neoplasms, and the mainstay of treatment is resection with negative margin. Soft tissue sarcomas, polymorphic spindle cell and giant cell carcinomas, pulmonary blastomas, and pulmonary lymphoma are other rare malignant tumors of the lung. Benign lung tumors. The most common benign tumor of the lung include pulmonary hamartoma, inflammatory pseudotumor, sclerosing hemangioma, bronchogenic cyst, leiomyoma, and adenoma. Papilloma and soft tissue tumors including lipoma, inflammatory fibrous polyps, lymphatic lesions, clear cell tumor, teratoma, and thymoma are much less common but reported. Diagnosis may only be at the time of resection or with treatment of any associated symptoms, although uncommon. بسم الله الرحمن الرحيم. من TASRA pulmonary lung metastasis. Pulmonary metastatic disease أو pulmonary lung metastasis. Autopsy series have demonstrated that pulmonary metastases are present in 20 ل 50% of all patients who die of cancer. Most patients who develop pulmonary metastases are not curable, owing to presence of extrathoracic metastases and ineffective systemic chemotherapy. Pulmonary metastectomy is the only curative option for patients with pulmonary metastasis and can involve survival in selected patient group. Pulmonary metastectomy should be considered in patients with resectable intrathoracic disease with no extrathoracic disease and adequate cardiopulmonary reserve. There has never been randomized trial to determine survival advantage of pulmonary metastectomy. However, a large volume of retrospective data substantiates survival benefit of pulmonary metastectomy for many histologic subtypes of metastasis. Diagnosis. The majority of pulmonary metastases are diagnosed by surveillance imaging. Radiographic appearance of pulmonary metastasis is non-specific, and there is no pathognomonic radiographic feature that distinguish metastatic disease from primary lung cancer. Pulmonary metastases are predominantly subpleural and located in the outer third of lung field. When multiple nodules are present, the probability of metastatic disease rather than primary lung cancer increases significantly. Chest CT is the standard imaging technique for identifying and following lesion. PET CT is critical in workup of metastatic disease and can identify unsuspected extrathoracic disease and thereby improve patient selection for pulmonary metastectomy. Principles of surgical resection. Two main principles direct surgical approach for resection of pulmonary metastasis: complete resection of malignancy and maximal sparing of normal lung tissue. Because of their large peripheral location, most lesions are amenable to wedge resection. It appears that wedge resection is if feasible, is as effective as anatomic resection for treatment of pulmonary metastasis. For lesions that are more central, segmentectomy or lobectomy may be required. segmentectomy هنشيل segment أو lobectomy هنشيل loop. Of the 5206 cases of pulmonary metastectomy in the International Registry of Pulmonary Metastasis, 67% of patients underwent wedge resection أو lobectomy أو segmentectomy أو pneumonectomy. The VATS approach to pulmonary metastectomy has the advantage of less post-operative pain, shorter length of stay, few adhesion after reoperation, and better compliance with adjuvant therapy. The argument adjacent to the use of VATS approach to pulmonary metastectomy in the centers which centers on the belief that manual palpation of deflated lung is essential to identify metastatic disease. There is, however, no evidence to suggest that the timing of resection of nodules that would be missed by VATS resection, which are usually less than 5 mm, is critical for the final outcome. Moreover, many recent studies in several different cell types suggest that VATS resection of pulmonary metastasis yields comparable survival to thoracotomy. Although the standard accepted resection for primary lung cancer includes either complete lymphadenectomy or lymph node sampling, this is not true for surgical treatment of pulmonary metastasis. Hilar or mediastinal lymph node involvement is present in 35% of cases of resected pulmonary metastasis and is more common with carcinoma than sarcoma metastasis. Hilar or mediastinal nodal involvement negatively impacts survival in the setting of various metastatic tumor, and although it remains questionable as to whether lymphadenectomy affords a survival benefit, It is championed by some groups owing to its prognostic and staging benefits. Data on the outcome of adjuvant and neoadjuvant chemotherapy and radiotherapy for pulmonary metastases are limited. Histology and outcome. Mortality rates of pulmonary metastatectomy do not differ from those of resection for lung cancer and vary between 6 من 10 and 2%. Many retrospective series on pulmonary metastatectomy report overall 5-year survival rates of 30 إلى 40%. Data from International Registry of Lung Metastases demonstrate global overall survival of 36 and 5-year 26% at 10 years following complete resection of pulmonary metastases. These data represent the gamut of epithelial, sarcoma, melanoma, and germ cell histologies for which the benefit of resection was shown to vary depending upon specific pathology. Patients with germ cell tumors had far best survival, and the patient with melanoma had the worst. Survival of patients with epithelial tumors and those with sarcomas were similar. The most common primary histology for patients evaluated for pulmonary metastatectomy is colorectal carcinoma, and 35 إلى 45 5-year survival can be attained with resection. Sarcoma is the second most frequent source of metastasis to the lung, and up to 50% of patients the lungs are the only site of metastasis. 5-year survival rate من 25 ل 35 are seen for pulmonary metastasis for sarcomatous metastasis. Encouraging results are also seen in renal cell cancer, gynecological cancers, and head and neck cancers. Pulmonary metastatectomy for metastatic breast cancer is controversial because of the availability of other effective systemic treatments such as chemotherapy, hormonal therapy, and targeted molecular therapy. Besides histology, factors associated with improved survival in patients undergoing pulmonary metastatectomy include prolonged disease-free interval from the time of resection of primary tumor to appearance of pulmonary metastasis, and the lower number of pulmonary metastases. In almost all series, the strongest predictor of survival is complete resection. Finally, repeat pulmonary metastatectomy may be required when there are isolated recurrence in lungs. Of patients undergoing pulmonary metastatectomy, 40-80% will suffer a pulmonary recurrence. Repeat pulmonary metastatectomy has been shown in international registry and several subsequent databases to afford long-term survival advantage in patients that qualify for repeated procedure. بسم الله الرحمن الرحيم. TASRA Cardiac Anatomy. Cardiac Anatomy Chapter 37. 2/3 of the cardiac mass lies in the left of the midline. Right ventricle anterior, left atrium posterior, left ventricle to the left, and right atrium is to the right. Right ventricle anterior, left atrium posterior, right ventricle anterior, left atrium posterior, left ventricle to the left, and right atrium to the right. The aortic valve occupies central position wedged between all of the other 3 valves. Aortic valve has a non-coronary leaflet which has fibrous continuity of the anterior leaflet of the mitral valve. The atrioventricular groove is obliquely oriented closer to vertical than horizontal. This is evidenced when palpating coronary sinus traversing and traveling in the atrioventricular groove for retrograde cannula placement. Pericardium. The heart lies within the pericardial sac, which is attached to the great vessels. The heart is enveloped in visceral pericardium, which also is adherent to the first several centimeters of the great vessels. The parietal pericardium lines the inner surface of the fibrous pericardial sac. The parietal pericardium lines the inner surface of the fibrous pericardial sac. There are two pericardial recesses, transverse and oblique sinus. The transverse sinus is bounded anteriorly by the aorta and pulmonary artery. Transverse sinus is bounded anteriorly by pulmonary and aorta and posteriorly by the interatrial groove. The oblique sinus exits behind the left atrium between IVC and pulmonary veins. The phrenic nerve, mediastinal nervus. The phrenic nerve descends anterior to the scalenus anterior, just posterior to the internal mammary artery. It is at risk for injury during internal mammary artery harvesting and takedown. Phrenic nerve then passes anterior to the pulmonary hilum and travels to the diaphragm. The left phrenic, if there is persistent left superior vena cava, will be plastered to its lateral aspect. The right phrenic attached to the lateral surface of superior vena cava and can be injured during dissection for superior vena caval cannulation. The vagus nerve. The vagus nerve courses along the carotid arteries and enters the thorax posterior to the phrenic nerve. The left vagus descends between left common carotid and left subclavian artery posterior to the aortic arch. The left recurrent laryngeal nerve comes off and hooks anteriorly around the ligamentum arteriosum and ascends to the tracheoesophageal groove. The right recurrent laryngeal nerve branches from the right vagus under the right subclavian artery and passes anteriorly to ascend out of the thorax. The vagus continues posterior to the pulmonary hilum. Anatomy of the coronary arteries. The coronary Bismillah ar-Rahman ar-Rahim. TASRA review of cardiothoracic surgery. Anatomy of the heart or cardiac anatomy. Tultain cardiac mass lies to the left of the midline. في عندنا تلتين الهارت بيقعوا في الناحية الشمال. 2/3 of the cardiac mass lies to the left of the midline. Right ventricle is anterior while left atrium is posterior. Left ventricle is to the left and right atrium to the right. يبقى بنبدأ بالRV. RV anterior أول حاجة بنلاقيها وراه left atrium. left ventricle على الشمال. left ventricle is to the left والرايت atrium على اليمين. يبقى الحاجة على اليمين الوحيدة هي الرايت atrium. طب على الشمال left ventricle. قدام الرايت ventricle ووراه left atrium. The aortic valve occupies a central position and wedged between all of the other three valves. The aortic valve central in position and wedged between the three other valves. الأورتيك فالف عندنا في رايت وليفت. في عندنا رايت كوروناري وليفت كوروناري ونون كوروناري. الليفت والنون كوروناري leaflets has fibrous continuity with the anterior mitral valve leaflet. يبقى النون كوروناري leaflet of the aortic valve has a fibrous continuity with the anterior leaflet mitral valve. أكتر حاجة هي non-coronary leaflet has fibrous continuity with the anterior leaflet of mitral valve. The AV groove is obliquely oriented and closely related to the vertical than horizontal plane. The atrioventricular AV groove is obliquely oriented and closer to vertical than horizontal plane. And this is evidenced by palpating the coronary sinus to be traveling in the AV groove for retrograde cardioplegia. This is evidence AV groove is being oblique. This is evidenced by palpating the coronary sinus. Coronary sinus دي في ال AV groove واحنا بنعمل retrograde cardioplegia cannula placement. Anatomy of the pericardium. The heart lies within the precardial sac which is attached to the great vessels. The heart lies within the precardial sac which is attached to the great vessels. The heart is enveloped into the visceral pericardium, which also is adherent to the first few centimeters of the great vessels. Parietal pericardium. في عندنا visceral pericardium و parietal pericardium. Parietal pericardium lines the inner surface of the fibrous pericardial sac. في parietal pericardium في عندنا fibrous واللي هو في parietal pericardium. Parietal pericardium lines the inner surface of the fibrous pericardial sac. There are two pericardial recesses, transverse sinus and oblique sinus. Transverse sinus is bounded anteriorly by the aorta and the pulmonary artery and posteriorly by interatrial groove. The oblique sinus behind the left atrium between IVC and pulmonary veins. Mediastinal nervus, the phrenic nerve. The phrenic nerve descends anterior through the scalenus anterior muscle, posterior to the internal mammary artery. The phrenic nerve descends anterior to the anterior scalene muscle, posterior to the internal mammary artery, where it is at risk for injury during internal mammary takedown. It then passes anterior to the pulmonary hilum and travels to the diaphragm. The left phrenic nerve, if there is persistent left superior vena cava, will be plastered to its lateral aspect. The right phrenic nerve is attached to the lateral surface of superior vena cava and can be injured during dissection for superior vena caval cannulation. Anatomy of the vagus nerve. The vagus nerve courses along the carotid arteries. الفيجاس nerve له علاقة بالcarotid arteries. The vagus nerve courses along the carotid arteries والفيجاس بيبقى مع carotid sheath في الcarotid arteries. والفيجاس بيخش الثوركس posterior to the phrenic nerve. The vagus nerve courses along the carotid arteries and enters the thorax posterior to the phrenic nerve. الليفت فيكس بيمشي بين الليفت كومن كاروتيد والليفت سبكليفيان ارتري ورا الاورتيك ارش. The left vagus descends between left common carotid and left subclavian artery posterior to the aortic arch. يبقى الليفت فيجاس بيبقى ورا الاورتيك ارش بين الليفت كومن كاروتيد والليفت سبكليفيان. The left recurrent laryngeal nerve comes off and hooks anteriorly around the ligamentum arteriosum and ascends to the tracheoesophageal groove. The right vagus بيطلع right recurrent laryngeal nerve which branches from the right vagus under the right subclavian artery and passes anteriorly to ascend out of the thorax. The vagus continues posterior to the pulmonary hilum. Anatomy of the coronary artery. The coronary orifices are located in the upper third of sinuses of Valsalva. coronary orifices arise أو بتقع في upper third sinuses of Valsalva. There are three main coronary arteries: RCA, LAD, and circumflex. Dominance of left or right is defined by supplier of the posterior descending artery, which comes from the right coronary artery in 90% of cases. The left main coronary artery courses of the left sinus of Valsalva behind pulmonary artery anterior to the left atrial appendage. Left main coronary artery bifurcates into LAD and circumflex, ولكنه قد يحدث له trifurcation in the setting of ramus artery. The LAD is the interventricular artery and courses along the anterior interventricular groove towards the apex. LAD gives septal perforators that dive down perpendicularly into the septum and gives also diagonals that course over the left ventricular anterior wall. الdiagonals بتبقى في anterior wall، وكمان ال LAD بيدينا right ventricular branches to the anterior surface of the RV. The left main coronary artery courses of the left sinus of Valsalva behind pulmonary artery anterior to the left atrial appendage. The left main coronary artery bifurcates into LAD and circumflex or trifurcates in the setting of ramus artery. The LAD is the interventricular artery that courses along the anterior interventricular groove towards the apex. It gives off septal diagonals and right ventricular branches. The septal perforators dive down perpendicularly into the septum. The diagonals course over the LV anterior wall. The diagonals course over the LV anterior wall and the right ventricular branches course to the anterior surface of the RV. The circumflex artery travels in the left AV groove and ends near the obtuse margin of the LV. In 15% of people, it continues in the groove and gives rise to the PDA in case of left dominance. In case of left dominance, it also supplies the AV node. The circumflex gives rise to obtuse marginals OM branches that supply the lateral wall of the LV. يبقى diagonals بتاعت LAD بتسبلاي anterior wall of the left ventricle while OM بتسبلاي lateral wall بتاع LV and the posteromedial papillary muscle. Obtuse marginals supply the lateral wall of LV and posteromedial papillary muscle. The circumflex supplies the sinoatrial node in 50% of people. The circumflex supplies the sinoatrial node in 50% of people. RCA courses from the aorta anteriorly and descends in the right atrioventricular groove to give off right ventricular acute marginal branches that supply the RV free wall and may continue in 20% of population across the diaphragmatic surface to supply the distal interventricular septum. The right ventricular acute marginal branch supply the right ventricular free wall and may continue in 20% of patients across the diaphragmatic surface to supply the distal interventricular septum. The SE node artery arises from the right coronary artery in 50% of patients. The SE node artery arises from RCA in 50% of patients and usually the first branch. The right coronary artery may give off an early coronal branch that courses to the left of the infundibulum. The right coronary artery bifurcates into PDA and right posterolateral artery. The PDA courses along interventricular groove towards the apex and gives off septal perforators that typically supply the posterior 1/3 of the septum. The right posterolateral artery gives off branches. The right posterolateral artery gives off branches to supply wall of the LV. Coronary veins. Coronary veins usually have no valves. The coronary sinus largely drains left ventricle and receives 85% of coronary blood flow. The rest drains via Sebacean veins into the right atrium. One of the main tributaries is the anterior interventricular vein with the LED. The great cardiac vein travels in the AV groove and turns into coronary sinus. The great cardiac vein travels in the AV groove and turns into the coronary sinus. Posterior interventricular vein with the PDA is the last tributary and drains near the coronary sinus orifice. This explains why right ventricular protection from retrograde cardioplegia can be marginal, as the cardioplegia catheter is usually inserted beyond the entry point of the vein. In addition, persistent left superior vena cava will drain into the coronary sinus, making it ineffective to administer retrograde cardioplegia unless the left superior vena cava is occluded and the flow is diverted. Anterior right ventricular veins drain into the right AV groove to form the small cardiac vein, which drains directly into the right atrium or coronary sinus. Sebacean veins are small veins that drain directly into the chambers, mainly the right atrium and the right ventricle. Anatomy of the right atrium and tricuspid valve. The SCA node lies in the junction of the right atrium and the SCVC. It is between right atrial appendage and the SCVC. 10% of patients have horseshoe SCA node, which is draped along the SCVC مفروشة على ال SCVC and right atrial junction. Fossa ovalis is the true interatrial septum, and its location it is the location where the left atrium should be entered for transseptal approach. It is also the location of patent foramen ovale. Sebacean vein is the valve of coronary sinus. Sebacean valve is the valve of coronary sinus. The Eustachian valve is the valve of IVC. IE و CT. CT يبقى coronary sinus Sebacean valve و IE يبقى IVC Eustachian. The tendon of Todaro is the continuation of Sebacean valve to the Eustachian valve. What is the tendon of Todaro? Tendon of Todaro is a continuation of Sebacean valve to the Eustachian valve. The atrioventricular AV node lies within the triangle of Koch. The AV node lies within the triangle of Koch. Triangle of Koch is bounded by tendon of Todaro, orifice of coronary sinus, and septal leaflet of tricuspid valve. Triangle of Koch is bounded by tendon of Todaro, orifice of coronary sinus, and septal leaflet of tricuspid valve. The bundle of His is located at the apex of triangle of Koch prior to branching on the interventricular septum. Trabeculated muscle surrounding the right atrial appendage marks abrupt transition to smooth atrial muscle at a well-defined band of muscle called the crista terminalis. The smooth atrial muscle marks the vestibule of the right atrium, which funnels into the tricuspid valve. Tricuspid valve has septal anterior and inferior leaflets. The tricuspid valve has septal anterior and inferior leaflets. Even though it is in continuity with the fibrous skeleton of the heart, but it does not have a true fibrous annulus circumferentially. The AV node is at the base of the septal leaflet. The AV node في triangle of Koch is at the base of the septal leaflet. The aortic valve is nearby to the junction of the septal and anterior leaflet. Anatomy of the left atrium and mitral valve. The left atrium has large fibrous component, which is a part of the chamber into which pulmonary veins drain. It has also appendage and vestibule funneling blood into the mitral valve. Left atrium is the most posterior chamber of the heart. Left atrium is the most posterior chamber of the heart, and surgical access is gained via incision anterior to the right pulmonary veins أو incision في الدون أو transseptal approach via the right atrium. احنا عندنا في 3 surgical access for the mitral valve. Incision anterior to the right pulmonary veins, incision in the dome, or transseptal approach via the right atrium. The mitral valve has anterior and posterior leaflets. The anterior leaflet has fibrous continuity with the aortic valve, and it's anterior to the surgeon's view as well. The anterior mitral leaflet covers only 1/3 of the annulus, but is longer leaflet. The anterior mitral leaflet covers only 1/3 of the annulus, but is the longer leaflet. The posterior leaflet covers 2/3 of the annulus, but is short with respect to depth of the orifice coverage. Though they may be divided by scallops, the leaflets are somewhat arbitrarily divided into 3 segments by Carpentier classification. A1 and B2 are the most medial and to the surgeon's left. A1 and B1 are the most medial or to the surgeon's left. A1 and B1 are most medial or to the surgeon's left. The leaflets are attached via chordae tendini to the posteromedial and anterolateral papillary muscle. The left side of the posterior leaflet is adjacent to the circumflex artery. Medially, the left side of the posterior leaflet is adjacent to the circumflex artery, and the right side or lateral side of the posterior leaflet is adjacent to the coronary sinus. يبقى في 2 سي related للposterior mitral leaflet، الcircumflex على الشمال والcoronary sinus على اليمين أو lateral. These structures اللي هي circumflex artery و coronary sinus can be injured with deep bites through the annulus. The right and the left fibrous trigones are dense collagenous tissues that bound the central fibrous body and are approximately at 10 o'clock position on the annulus. In relation to the anterior leaflet, they are both anterior to the valve commissures. Anatomy of the right ventricle and the pulmonary valve. The right ventricle outflow is composed of infundibulum and the tricuspid pulmonic valve. The pulmonic valve does not have a fibrous annulus but is rather suspended in muscle. It is the only valve that is not connected to the fibrous skeleton of the heart. The apex consists of trabeculated muscle and is quite thin. There is an anterior and medial papillary muscles suspending the tricuspid valve. Anatomy of the left ventricle and the aortic valve. The left ventricle chamber is composed of fine trabeculated muscle extending all the way to the apex. The mitral valve and subvalvular apparatus compose the inflow portion. The outflow tract is lined by smooth muscle and fibrous tissue. The septal portion of the left ventricular outflow tract includes the membranous ventricular septum. The left ventricular outflow tract also contains a fibrous sheath. The left ventricular outflow tract also contains a fibrous sheath, which extends from the anterior leaflet of mitral valve to the mitral aortic continuity, supporting the left and the non-coronary leaflet of the aortic valve. هنا قال بقى انها left و non-coronary. The left bundle branch enters the left ventricular outflow tract posterior to the membranous septum and between the right and the non-coronary cusps of the aortic valve. This can be injured during aortic valve surgery. Aortic valve is tri-leaflet valve. The leaflets coapt along a semilunar plane. The coaptation surface is thin, except centrally where there is a nodule of around teeth on each leaflet. The aortic wall bulges out from each leaflet to form the sinuses of Valsalva. The aortic root is composed of annulus, leaflets, sinuses of Valsalva, and sinotubular junction. The sinotubular junction is at the top of the commissures and is the point where the sinuses neck down to form the tubular aorta. Cardiopulmonary bypass. Cardiopulmonary bypass may be required in patients with coronary artery disease, valvular heart disease, aortic dissection, congenital defects, aneurysms, transplantation, or for hypothermic rescue. Cardiopulmonary bypass facilitates surgical intervention with a motionless, bloodless field. The bypass machine can isolate the heart and the lung while maintaining organ perfusion. It both serves as a pump and oxygenator, with pressure and oxygenation easily modulated by increasing flow rates on cardiopulmonary bypass. Unfortunately, the synthetic interface of the circuit also causes activation of blood components and cytokine release. Unfortunately, the synthetic interface of the circuit causes activation of blood components and cytokine release. Specifically, the membrane oxygenator exerts the most damage on blood components. The membrane oxygenator exerts the most damage on blood components. Another more infrequent complication with blood components occurs in patients with cold agglutinins that precipitate out with cooling on bypass. Another more infrequent complication with blood components occurs in patients with cold agglutinins that precipitate out with cooling on bypass. If recognized, every attempt should be made to do the procedure as at normothermy. The ischemic myocardium of the arrested heart is protected in three ways: electrochemical silence, cold temperature, and lack of distension. Ischemic myocardium of arrested heart is protected in three ways: electromechanical silence, lack of distension, cold temperature. The ischemic myocardium of arrested heart is protected by electromechanical silence, cold temperature, and the lack of distension. The ischemic myocardium of the arrested heart is protected in three ways: electromechanical silence, cold temperature, and the lack of distension. Cardioplegia. Cardioplegia is the most common method of accomplishing systole. It can be given antegrade and or retrograde. Antegrade cardioplegia is usually quicker at arresting the heart. الكارديوبليجيا بتاخد دقيقة علشان تarrest the heart. This is done using cardioplegia cannula that is inserted directly into the ascending aorta, or alternatively directly down the coronary ostia following aortotomy. Delay usually indicates a problem with delivery of the solution or unrecognized aortic regurgitation. Retrograde cardioplegia takes longer to induce electrical arrest من 2 ل 4 minutes and may provide incomplete protection of the right ventricle due to delivery of cardiopegia into the coronary sinus beyond the site of the first few veins that drain the RV. However, it does serve the advantage of flushing out air and the emboli from the coronaries. The heart arrests in diastole and does not use ATP during this period of heart isolation. Cold fluid at 4 degrees centigrade cools the heart, thus slowing down its metabolism. The cardioprotective effect of hypothermia are often expressed using the Q10 rule, which says that for every 10 degrees centigrade drop in temperature, metabolic rate decreases by 50%. Venous cannulation and drainage. The drainage amount is determined by CVP, height differential, use of vacuum, resistance in cannula and tubing, and the absence of air within the system. Inadequate blood volume or excessive siphon pressure may cause walls to collapse against the cannula and produce shattering. Volume corrects this. Most commonly, bicaval or cavo-atrial venous cannulation is used. Elevation of the heart making the cavo-atrial junction and partially obstruct venous drainage. Femoral and iliac vein cannulation can also be used and is especially useful in the following scenarios: emergency closed cardiopulmonary assist, prevention or management of bleeding during sternotomy, femoral and iliac vein cannulation can also be used and is especially useful in the following scenarios: emergency closed cardiopulmonary assist, prevention or management of bleeding during sternotomy and reoperative heart surgery, certain types of aortic and thoracic surgery, and application of cardiopulmonary bypass that do not require sternotomy or thoracotomy. What are the complications of venous cannulation? Venous cannulation can lead to several complications, including arrhythmia, tear and bleeding, air embolization, injury or obstruction due to catheter malposition, reversing of arterial and venous lines, unexpected decannulation and obstruction of KV with tying of improperly placed purse string sutures. In addition, there may be complications when placing tapes around the cava, such as lacerating venous branches, nearby vessels, the right pulmonary artery أو الكيفا itself. Arterial cannulation. Arterial cannulation is used to support circulation. Cannulation site is influenced by the planned operation and distribution of atherosclerotic disease. Cannulae are usually placed in the proximal aorta but can also be placed in any major artery, innominate artery, distal aortic arch, axillary or subclavian artery, or femoral and external iliac artery. What are the complications of arterial cannulation? High velocity jets out of the cannula tip can cause sandblasting effect. This can damage the aortic wall and dislodge atheroemboli and produce dissection. And also it can disturb flow to nearby vessels and cause cavitation and hemolysis. The debris is preferentially directed into the left common carotid artery, which explains the predominance of left-sided strokes following cardiac surgery. Other complications include difficult insertion, bleeding, intramural or other types of malpositioning of the cannula tip, failure to remove all air from the arterial line after connection,
Injury to the aortic back wall, obstruction to flow, inadequate or excessive cerebral perfusion, and delayed complications, late bleeding, and infected or non-infected false aneurysms. Epi-aortic ultrasound is the best method for assessing atherosclerosis of ascending aorta. Calcified aorta, porcelain aorta occurs in من 1 ل 4% of cases and is an indication for changing location of the aortic cannula. Aortic dissection occurs in 1 من 100 ل 9% of all aortic cannulations and is more common in patients with aortic root disease. First clues are discoloration beneath the adventitia near the cannulation site, increase in arterial line pressure, and sharp reduction in return to venous reservoir. Prompt action is necessary to limit dissection and maintain perfusion. Cannula must be promptly transferred to peripheral artery or uninvolved distal aorta. Blood pressure should be controlled medically. Perfusion cooling to temperature 20 is initiated. During deep hypothermic circulatory arrest, the aorta is opened at the longitudinal site at the original site of cannulation and then repaired by direct suture, patching, or circumferential graft. Early recognition brings survival up to 66 ل 85% of cases. If recognized after surgery, survival is approximately 50%. Lower body cannulation is associated with many complications, including tears, dissection, late stenosis or thrombosis, bleeding, lymph fistula, infection to the groin, and cerebral and coronary atheroembolism. Malposition can also be a problem in those with prior aortic dissection. Ischemic complications of lower extremity can occur with prolonged retrograde perfusion unless side arm is used to perfuse the distal leg. Retrograde arterial dissection. Retrograde arterial dissection is the most serious complication and may also Retrograde arterial dissection is the most serious complication and may also extend in an antegrade fashion to the aortic root. Incidence is 2 من 10 ل 1 ل 3 من 10 and is associated with mortality in about 50%. It is more likely to occur in diseased arteries and the patients over the age of 40. It is confirmed by echocardiography or descending thoracic aorta. Echocardiography of descending thoracic aorta. Venting the heart. If the heart is unable to contract, distension of either ventricles is detrimental to subsequent contractility. Distension can be insidious unless a vent catheter is used. Blood can enter this cavity from multiple sources: blood escaping arterial or venous cannulae, coronary sinus and epiphyseal veins via pulmonary circulation, bronchial, arterial, and venous blood, regurgitation from the aortic valve, or undiagnosed PFO or PDA. There are 4 main vents that can be used for this purpose: an aortic root vent, left ventricular vent via right superior pulmonary vein, left ventricular vent via the apex, and the vent of the pulmonary artery which has no valves in the pulmonary circulation. Persistent left superior vena cava. What is persistent left superior vena cava? BLSVC is present in 3 من 10.5% of population. It usually drains into the coronary sinus. However, in 10% of cases it drains into the left atrium. It should be suspected when the left innominate vein is small or absent and a large coronary sinus or persistent left superior vena cava is seen on baseline echocardiography. If these signs are missed, it should be considered when there is inadequate venous cannula flow with bicaval cannulation. It may complicate retrograde cardioplegia or surgical entry into the right side of the heart. If an adequate sized innominate vein is present, the persistent left superior vena cava can be occluded during cardiopulmonary bypass. But if the innominate vein is absent or small, occlusion of the persistent left superior vena cava may cause venous hypertension and cerebral injury. In these patients, cannula is passed retrogradely into the persistent left superior vena cava through the coronary sinus ostium and secured, or the posterior left superior vena cava is cannulated directly. If the right superior vena cava is not present in 20% of patients, the left superior vena cava cannot be occluded. بسم الله الرحمن الرحيم. TASRA Chapter 39 Adult Cardiac Surgery Coronary Artery Disease.